Good afternoon, ladies and gentlemen. Welcome to today's webinar. I would like to remind you that this conference is being recorded. At this time, all participants are in a listen-only mode. For those connected by telephone requiring operator assistance during the call, please press *0. Web participants requiring support should use the chat feature on your screen. I would now like to turn the meeting over to your moderator, Bill Callery, Senior Improvement Lead at the Canadian Foundation for Healthcare Improvement. Please go ahead.
Thanks so much. Well, hello everyone and welcome to today's webinar, Value-Based Healthcare by Design, Identifying Promising Innovations in a Canadian Context. And I see that many of you have already started introducing yourself on the chat box. So we look forward to hearing from many more of you, and it's great to see some familiar names and some new ones as well. So I want to begin the webinar by acknowledging that we're meeting on land that has been inhabited by Indigenous peoples for millennia. And in particular, we acknowledge that we're broadcasting this webinar from Ottawa, which is the traditional unceded territory of the Algonquin Anishinaabe people. We recognize and deeply appreciate their historic connection to this place and the opportunity to gather here today. So we're thrilled to have well over 300 registrants from coast to coast to coast, and already see about 70 people online right now. I'm Bill Callery, today's host and Senior Improvement Lead at the Canadian Foundation for Healthcare Improvement, or CFHI. Today's webinar is part 2 in a series of webinars on the topic of value-based healthcare. And before we get started, there's a few housekeeping items I'd like to mention. As I introduce our speakers next, if you haven't already done so, please take a moment to introduce yourselves using the chat box on the bottom right side of your screen. And we're pleased to provide simultaneous interpretation as well as a fully bilingual chat box for this webinar. If you're currently participating in English and would prefer to listen and view the slides in French, please let us know using the chat box. Throughout the webinar, please send in your questions on the chat box. We're going to stop between presentations to answer a few questions, and then I've reserved 15 minutes at the end of the webinar devoted to Q&A. Please also feel free to, if you have any resources you want to share, feel free to put those in the chat box. I'm sure others would love to hear about things of interest to you. And finally, for those of you on Twitter, we've got a hashtag for you, and you'll see on your screen it is VBHC Webinars, and you can join the conversation on Twitter. So a little bit about the Canadian Foundation for Healthcare Improvement for those who aren't familiar with us. We're a national not-for-profit organization funded by the federal government, and really we're focused on helping to achieve more healthcare improvement that reaches more people right across Canada and that lasts. And we do this in really 4 pretty complementary ways. So the first is tackling known problems that need solutions by helping to find, connect, and incubate innovators and their innovations in order to catalyze healthcare improvement efforts. The second area, which is where we spend a lot of our efforts, is where there are proven solutions. So for example, an improved way to treat and manage a chronic disease. Here we work with our partners, including patients and families, to help spread and scale up improvements across Canada. The third area is enhancing improvement capacity, for example, through our extra executive training program for health leaders and teams. And finally, the fourth area focuses on the policy and system enablers and barriers for healthcare transformation. So how can we help start hardwiring improvement into our healthcare systems? And this is really where our work on value-based healthcare comes in. So if you want to learn more about our work, including current opportunities to collaborate, our website is a great way to start. And again, for those just joining into the webinar, I'm Bill Callery. And at this point, I'm really excited to present our 3 presenters today, Jennifer Zellmer, Paul Larchevêque, and Eric Sandy. So Dr. Jennifer Zellmer is the President and CEO of the Canadian Foundation for Healthcare Improvement. She has a long-standing commitment to healthcare improvement, having held senior leadership positions with Canada Health Infoway, the International Health Terminology Standards Development Organization, and the Canadian Institute for Health Information. She is the Editor-in-Chief of Healthcare Policy, an adjunct faculty member at the University of Victoria, and a member of several health-related advisory committees and boards. As our first presenter, Jennifer will be providing a brief refresher introduction to value-based healthcare. What it is, what it isn't, key enablers, a set of assessment criteria that can be used for selecting or developing a value-based healthcare initiative. And for anyone looking for a bit more introductory and content, we encourage you to review the recording from our Part 1 webinar last month, and also have a look at our executive briefing report and case studies, which are found on our website. And we'll put both links to those in the chat box. Our second presenter is Paul Larchevêque. Paul was appointed the first ever Leader of Innovation at Quebec's Ministry of Health and Social Services Innovation Bureau last year. Paul has a master's in neurophysiology from the University of Montreal and has been a key figure in many high-profile developments in Canadian life sciences. Prior to his current role, Paul led Genome Quebec as a CEO for 8 years and possesses an extensive experience in the private pharmaceutical sector. Notably, Paul is also a senior partner at Cap Cogito, a consulting firm focused on helping to integrate innovation into the public health and social services sectors. And for his part, Paul's going to be using the value-based healthcare assessment criteria that Jennifer presents as really a jumping off point from which to introduce a set of ministry tools that are being used by the Innovation Bureau in Quebec to help develop and ready healthcare innovations for implementation. Our final presenter will be Eric Sandy, President of MetaV Health Services. At MetaV, Eric leads a team of healthcare professionals delivering out-of-hospital emergency medical services and home-based primary care across 6 Canadian provinces. Eric's career spanned a variety of industries, including healthcare, financial services, energy, and communications. He has significant experience and expertise leading high-growth technology and healthcare service companies across Canada, the U.S., and international markets. And Eric also participates on a number of boards, including our own here at the Canadian Foundation for Healthcare Improvement. Building on the case profile summary on our website, Eric's going to describe in more detail the integrated primary healthcare model in New Brunswick, Extramural, and highlight the unique value-based healthcare funding agreement that really underpins the initiative. So welcome, and thanks everyone for joining us. And now I'll turn it over to you, Jennifer, to start us off.
Thanks so much, Bill, and let me join Bill in welcoming everyone to today's call. So my task in starting us off, as Bill said, is to give a brief overview of value-based healthcare, really to provide some of the context for our discussions today about how different organizations, different parts of the country are applying those principles in practice. So Bill, if I can get you to move to the next slide. There are many ways of describing the health systems across the country, and one thing that we can definitely say is that the health system is not simple, and in fact not even complicated, but rather complex. And there are many characteristics of complex adaptive systems and how to manage within them. One of those characteristics is that we need to think about what are the simple rules that various players in a complex adaptive system, in a network with relationships, can use to help coordinate and move towards a common set of goals. And one way of thinking about value-based healthcare is as one of those simple rules. Now I say simple, but actually it's hard to do the simple. So it is about finding those guiding lights and stars to steer by that allow us to move forward. If we can move to the next slide. For the purposes of this webinar and our work on value-based healthcare, we've been using the definition from Porter and Teasdale that really compares outcomes that matter to patients with costs over the patient's journey. So it allows us to link and think about together those two different factors, the things that matter to patients at the end of the day, the things that allow us to focus on the important, and also not just slices of the patient's experience, but rather a full episode of care or a full set of experiences. It does allow us to focus on those outcomes rather than on, say, the numbers on counts, the numbers of things that may be done, or specific how-tos that may or may not achieve those outcomes. And if we can move to the next slide, Bill. Value-based healthcare is a concept that has been around for a while under different labels, different formats, but is really increasingly being seen as a way of focusing on what matters to patients. So you can see this comparison from the World Economic Forum, arguing that it has the potential to deliver substantially improved health outcomes at a significantly lowered cost. But while we talk about some of the things that value-based healthcare is, and as Bill said, if you're interested in more of that sort of foundational, what is this, how does it work? I encourage you to have a look at the executive briefs on our website and some of the earlier materials. It's also important to understand what it's not. So, Bill, if we can go to the next slide. This is not about containing costs specifically. It is about that comparison, about looking at the relative difference between changes in outcomes that matter to patients and the total costs over a journey. It's also not just about a particular slice of costs, so a particular time period in a hospital stay or a particular component of an overall episode of care. Rather, it's typically about looking at the entire episode, or in fact, in some cases also, the entire set of care experiences of a population group. So possibly, for instance, people with advanced COPD. Equally, it's important to say it's not the same as a straight-up pay-for-performance model that says if you do X, you get paid Y, because those are typically focused on processes of care rather than on the outcomes. And increasingly, people are thinking about value-based healthcare broadly. So it may include considerations around, for instance, social services or housing or other elements that can contribute to outcomes that matter to patients in a particular context. So Bill, if we can move to the next slide, how do we get there? If that's what we're aiming to do, how do we get there? There have been a number of studies done globally, so this is really the cold notes version that cuts across what those studies have identified as key enablers of value-based care. And if you're interested in the underlying studies, you will find all of the links in the executive brief that Bill mentioned earlier. So what are some of those key enablers? The first is having that core set of enabling context, policy, and institutions. So the framework, if you like, that makes it easier to focus on outcomes, easier to focus on the patient experience. The measurement of costs and outcomes is also important. After all, it's hard to compare a change in those two things if you're not sure where you're starting from and where you're going to. And increasingly interested in understanding how those compare with a variety of different options. Another key enabler of value-based care is care pathways and integration. So the more work that has already been done in understanding episodes of care, in understanding how individuals may move through a care pathway, may move through different parts of the health system, may have different experiences with those aspects of the health system, and already have coordinated some of those pieces, the easier it will be to introduce value-based healthcare. And last but not least, outcome-based payment approaches. So having thought that through in advance, having those already worked through certainly makes it easier to move forward in a value-based healthcare context. Now, it is, of course, the case that many folks who are focused on value-based healthcare may not have all of these enablers in place to the same extent, but it helps us start to think about what makes this kind of path possible and, in fact, easier to do. If we can move to the next slide, Bill, there are, although some of the international examples have maybe been higher profile, there are indeed a number of Canadian examples of value-based healthcare, and you'll hear, as I said earlier, a couple of examples on today's call about how people are applying these principles in Canada. But if you're interested in more examples, you'll find a series of case profiles that are also available on our website. So in some cases, people may have focused on outcome-linked funding, whether that's through things like blended payment models or through things like actually linking outcome-based measures to the funding received. You'll also see examples like social impact bonds. So possibly the highest profile example in Canada is the work that the Heart and Stroke Foundation is doing. These tend to be longer term and to focus on things where you may have had to have had a period of leading up to an outcome. So for instance, some of the preventative type interventions, population health type interventions that may have a longer time frame to actually see the impact on the outcome at the end of the day. We're also increasingly seeing value-based procurement that involves risk and gain sharing. So there are a number of examples of this in the pharmaceutical space, but also in areas, and for those of you who are on our first webinar, you would have heard the example from Ontario of cardiac device procurement that started with the foundation of what are the outcomes that matter to patients, and use those to actually drive the criteria in the procurement, and then link that also to the risk and gain sharing elements of the procurement. So if you're interested in more examples like that, you may want to go back to the first webinar or also look at some of the additional examples that are profiled on the website. And we're always interested in more examples as well. So if you have examples that you're involved in, please feel free. Type them into the chat box to give us some starting points for everybody on the call today, or get in touch with us afterwards because we'd love to know more as well. And in fact, it was a number of folks moving down this path that drove us to the next piece of work that we started to do over the summer. So Bill, if we can move to the next slide. We had a number of groups who across the country were wrestling with the issues of, okay, so where should we start in value-based healthcare? Or if we're going down the path of value-based healthcare initiative, how do we assess our relative readiness and risks? So where are the areas that we might need to focus on more? What are the things that we might need to do to de-risk some of these initiatives on the way? And that's equally applicable to those in the public sector and those who may be suppliers into the public sector if we're talking about value-based procurement. Both groups were interested in these kind of questions. So we held a design day over the summer, and we asked people who'd been involved in value-based healthcare initiatives, what are the core things that we need to consider in identifying promising initiatives or in assessing the relative risk as we go down the path of different initiatives? And we've since tested a number of those criteria. So Bill, if we can move to the next slide, you'll see that there are a series of 12 criteria that have been identified and that seem to be standing up in the testing, but we would welcome your advice and thoughts based on your experiences today as well. So I'll just run through a few of them to give you a sense, and the tools that are being developed are also available through our website, and there'll be more to come on this front as well. So the first is meaningful metrics, and there's two aspects to this. The meaningful means that the work has been done to understand what is meaningful, which outcomes are meaningful to patients and families, and then be able to translate that into metrics that allow us to look robustly at changes in those outcomes over time, or in particular comparisons of different types of interventions. Once you have metrics, you also need data. And that's on both the cost and the outcome side, so both the numerator and the denominator, the ability to measure data. And it's obviously an easier path if those data are already being measured in a robust, comparable way, but that's one of the areas to assess. Equally, we heard loud and clear that clarity of scope matters. So being able to understand for which groups of people are we focused and for which types of outcomes are we looking at, so that there's an ability to draw a bit of a box around the outcomes and the costs that will be considered as part of a value-based healthcare initiative. The next one seems obvious in hindsight, but is not always something that's focused going in, so hence why folks encouraged us to include it as part of the assessment, and that's the material impact. So making sure that the effort that goes into the design and delivery of a value-based healthcare initiative is actually targeting an area where there is significant possibility of changing that ratio of outcomes that matter to patients relative to the cost over the patient's journey. And then you'll see a number of other areas that were also identified. Some of them are classic areas in terms of any kind of change management, like effective clinical leadership, having the dedicated resources, and importantly here, not just the money, but also the people and the time to be able to focus on this type of initiative rather than doing things off the side of a desk. Permeability between silos being a fancy way of saying, assuming that you're looking at a full patient journey, there are typically multiple organizations, multiple sectors involved in that journey, so the ability to consider that full journey and to be able to focus on a pathway across that, both on the cost and on the outcome side. Supportive policy and structures of the kind that we spoke about earlier, similarly aligned payment models, the capacity and skill for value-based healthcare, not just in one aspect of the partners involved in a potential initiative, but across the board. And then it is an easier path when proven solutions are in place and we can leverage those going forward, although some types of value-based healthcare, like open innovation models, may actually start from a place of saying, we actually don't know what the most effective solutions are, but we can identify the outcomes that we're looking to achieve. And last but not least, the time to achieve value. And as I spoke about earlier, the acceptable or expected time to achieve value may differ across different kinds of value-based healthcare initiatives. Maybe shorter for a procurement, for example, longer for a social impact bond, or in the context of a blended payment model and approach. Equally, in the context of an accountable care type of environment, you may have differing expectations of time to achieve value. So that's a very rapid introduction to some of the key concepts of value-based healthcare to help be a jumping off point for today's call. And I think Bill will put up the last slide in this segment, again with the links there. If you want more information, you want to delve into this further, you've got some additional resources that are available there to get started, as well as just posted a series of profiles of some of the Canadian value-based healthcare initiatives. And so with that, maybe I'll pause there, Bill, and see if there's any immediate questions that have been raised during the course of this presentation, and remind everyone that you have an opportunity to pop those questions into the chat box at any point during the call.
Thanks so much, Jennifer. So we've got questions coming in. I've got 3 here on your list, and I know you're dialing in from Whitehorse and have to sign off pretty soon. So I'll go through the questions now. The first one from Patrick in Saskatchewan. He says, I'm working to bring the concept of improved value as opposed to ROI in Saskatchewan. Are you aware of any provincial health systems that have taken significant strides in improving value, and how did they begin? Another question from Maggie is interested in hearing more about how risk sharing is promoted in value-based healthcare.
Great, so let's start with those. So I don't want to steal Paul's thunder, so I'll leave you, Paul, to talk about what's happening in Quebec. There are a number of other efforts that are happening across the country, some earlier, some later stage. A number of jurisdictions, for instance, and even collectively on the pharmaceutical side have been looking at value-based healthcare initiatives that relate to medications. There are also a number of jurisdictions that have been looking at different types of models for particular types of services. And I won't steal Eric's thunder either by talking about the experiences in Atlantic Canada on that front. So there's a couple of examples coming up where I think significant strides are being taken in that regard. But I think it's also fair to say that globally this is relatively new at scale. And so there are opportunities for all of us to learn from some of those early experiences and then to be able to build on those as well. And Maggie, in terms of your question, and great to know that you're on the call, there are actually a variety of ways for looking at risk and gain sharing in a value-based healthcare context. So if you think on the funding side, for instance, a blended payment model may allow you to look at payment funding across different sectors of the health system. So for instance, not just the surgical component, but also pre-surgical preparations and post-surgical follow-up. And by blending those payments together, you have the opportunity of looking at some different approaches to being able to share some opportunities for early intervention, for instance. So that often it's the case that in a traditional, somewhat siloed funding model, the group that would have to pay for some of those early interventions or for some of the indeed post-surgical follow-up examples is not the group that would actually benefit from any types of cost reductions. And so being able to put some of those funding envelopes together may allow you to look more creatively at how you would work in different ways. On the procurement side, you also do see some risk and gain sharing types of approaches. Similarly, in the social impact bonds, so if we take the social impact bond example, typically those are set up so that investments are made up front by the investors of the bond, and then returns from that bond depend on the level of outcomes that are achieved based on pre-specified outcomes, obviously. So if there is more success, for instance, in preventing the progression of hypertension, preventing serious cardiac events, then the returns could be higher than in cases where that wasn't achieved. On the procurement side, it may be the case that, for instance, payment for, well, we had the example on the last call, one of the outcomes that was really important to patients in that context was not having to have a second cardiac surgery because, for instance, the battery would be low in your pacemaker or other device. And so they built in to the procurement requirements around the longevity of some of those devices. And if those if that longevity wasn't achieved, then there's the option of looking at risk sharing in that context. So I hope that helps with some of those sort of initial examples. If you're interested in more about the experience on the cardiac side, I do encourage you to have a look at that first webinar, because Dov laid out in a fair bit of detail how that actually gone about working with individual and groups of patients to identify what mattered to them, and then building that into the whole procurement process.
Great. Thanks so much, Jennifer. And we got a nod from Maggie that yes, that answers her question. I've got a number of other questions and comments coming in, really excellent excellent input. I'm going to hold these for the question and answer period at the end. And I know, Jennifer, you've got to run to some meetings there in Whitehorse. And I want to move next to Paul Larchevêque. So as I mentioned, Paul is the leader of innovation at the Innovation Bureau in Quebec's Ministry of Health and Social Services. And Paul will be, in light of the criteria presented by Jennifer, discussing some of the tools that the Innovation Bureau is using. So Paul, over to you.
Thank you very much, Bill, and it's a pleasure to speak to all of you. I want to thank the CFHI, Jennifer, and Bill for inviting me and providing me this opportunity to share some of the stuff that is happening currently in Quebec, and I'll go quickly through the slides. First I'll start with the Innovation Bureau mandates, where we've been created to accelerate the access to innovation. As in many jurisdictions, we're not always very quick at integrating new tools, new practices, and we needed to do something about that, and that's the purpose of the Bureau. That includes all types of innovation, the social, the organizational, and the technological innovation. So it's quite wide. That's a bit of an issue, but we're trying to solve that, and we've been putting some stuff in place so that we could tackle this issue. What we're really trying to do is to move towards a value-based healthcare system, and that's quite a challenge, and that requires a change in a profound change, I would say. It's not a cosmetic change, it's really a cultural change, and that requires a lot of effort. And what we're trying to do, among other things, is to contribute to the sustainability of the healthcare system and to create at the same time a favorable business environment. So those are the mandates that we've had, and that includes, although it's not specified here, value-based procurement initiatives, which we've been working with and trying to establish in the province. The other slide is what is it we've done with that, and basically we've created a tool which we're calling, it's not very original, and we excuse us for that, but we're calling it our business plan approach. And what we're trying to do with this business plan approach is to provide a tool for the innovators, whether they're coming from the healthcare system or the industry, to speak a language which is going to be easier to understand and will provide them the opportunity to present all of the critical information in a very short and impactful way, so that we can assess it and look at it in its most favorable way. Here, what we've been doing with this business plan approach is basically what we're trying to do is to make sure we understand, we describe the importance of the need that is being addressed and the appropriateness of the solution which is being offered. We're working with optimal healthcare trajectories. You're going to start seeing some similarities with Jennifer's presentation, and that's the common language we want to have for all innovation that are being presented. We want not only the trajectory to be described, but even more specifically the outcomes, the benefits for the patients, the clinical benefits, and the healthcare system and efficiencies benefits. We want those to be very clearly described. And then we're also asking questions about feasibility, connectivity with the tools that already exist in the system, and the rollout program, which are so often forgotten at the beginning of the process but are so critical when you get there. What are the reimbursement strategy and the demonstrated economic benefit outcome, and in some cases, what are the other social economic benefit that can be derived from that. The tools, there's basically the tool for the business plan, I think, is available in the material of the webinar, and you can look at it, and you can also access it at the Ministry of Health website. Just a word, this is working. This is has been working, and we have a full cycle of putting that in place. The next part of the presentation, and I'll go quickly, is when I was at the conference in August, I think it was in August with the CFHI, and they were working on the concepts of those assessment factor. I was fascinated by the correlation that can be established with some of the stuff that is in the business plan and the assessment factor that were described at the meeting. And I'm not going to go through all of the example, but this is a tool, and I'm sure there are many other tools, and I'm not pretending this is the best one. I'm just saying it's interesting to do this correlation, because what this is allowing us to do is, first, it's confirming to us here in Quebec that according to the conversation that was held at that meeting, that we're not so far off in terms of those tools and moving towards a value-based healthcare. And it's also providing a way to take those concepts and put them into a real meaningful environment and helping us making decisions. So, and those are on the left-hand side, you'll see the criteria that were presented by Jennifer. The first one is meaningful metrics. And what I've been doing basically is I've been extracting from the business plan tool what were the requests we were making that were making sure we were addressing some of those assessment factors. So here on the first one, we're asking people to talk to us about the prevalence, the target population, the cost, the loss of efficiency, and so on and so forth. So, and that is the basis on which we can build the meaningful metrics. On the outcome and cost data, we're asking them what are the expected results, which are the outcomes, and I've described patient, clinical, and healthcare system outcomes, and what is the budget required to achieve and to arrive to those outcomes. The clear scope is defined because we're asking the people to specifically describe in which health trajectory this innovation is contributing to. And the next one, which is the material impact, is if we were to introduce this innovation, what would be the health trajectory, the new health care trajectory that would be derived from the introduction of this innovation? And then we can compare the two and start having a very clear understanding on the material impact that will be generated if we are to go ahead with this innovation. And so on and so forth. And I'm not going to present all of the categories except for two. I'm going to talk about the clinical leadership, just to say that we're using the official clinical guidelines, not only the one in Quebec, but we're comparing to other ones in the country and internationally to make sure that we understand where we stand against some of the other practices around Canada and around the world. And I'm going to talk about number 7, the permeability, and that's between the silos, which we should have included in the description. And that only to introduce the notion of the Prioritization Committee. And this committee is where we take the business plan. So we ask the innovators to build a business plan, then we take it to the Prioritization Committee. And that's a committee which is created of key decision makers at the Ministry of Health and in the healthcare system. And then that is allowing us to provide feedback to the innovators right from the people that are going to be implementing that in the future if we were to go ahead with those. And again, that goes, I'm not going to describe all of them. You have them. You can take a look at them, and if you have questions, you may ask questions to me. I'm just going to close quickly here on some additional perspective. We have presented to you the short business plan process. Once we've got approval with the short business plan, there's a longer process. It's only a 3-page plan that is being required. This is very efficient for the innovator, very efficient for decision maker. But if we go ahead after the short business plan, we're asking people obviously to build a longer plan. This is a 10-page plan. This is focusing a lot more on implementation and making sure we understand all the issues related to implementation. The other point is on the integration side, the work we've been doing looks pretty good. We've had some successes. We're happy with the progress. But on the implementation side, there remains big challenge, and those are how do we spread that within the healthcare system. The scale and spread issue is really a big issue, which this process is not quite solving. So we understand that we need to work on that. The last point is almost a philosophical point, but nevertheless, it's probably an important point, is the question is, very often the efficiencies required, the innovation requires out-of-pocket expenses, and the efficiencies that are gained do not translate into what I call cashable synergies. And we'll need to find a way to tackle that, because we cannot expand forever the budget of the healthcare system. So the final point is this process may look a bit reactive, and in the first year of its implementation, we only have been in place for a year. It was quite a bit reactive. We receive innovators and their innovation, and we help them through this process. We want to move in year 2 to a more proactive approach, trying to tackle major health issues, problems, and try to find portfolios of innovation or portfolios of solution as opposed to one solutions at a time. And so that's where we will be moving in the next year. And I'll stop here and answer any questions if there are any questions.
Great, thanks so much, Paul. And for people on the webinar, just note that we've put in links to both the business plan writing guide and the overview document of the steps in the innovation project, so you have access to those in both French and English. And a question to you, Paul, from Maggie is, how are you addressing the spread and scale issue, which seems to be a universal problem?
As I've just mentioned in the very, very last point, is this is not our best practice yet, and we need to work on that. This is going to be, along with the more proactiveness focus for year 2. But the way we're doing it basically is what we're currently doing now is we're doing a kind of an inventory map of the major innovations happening, and we're trying to bring people from different organizations to work when they're working on similar type of problems, to bring them together early so that we develop solutions which are applicable to many different places, and we can then contribute to the spreading of the practice. The other thing we need to do is we need to take the innovation and create the time in the organization to adapt the innovation to them and to implement it, but we have still some work to do in that direction.
Great. A few other questions coming in, so we'll take one more now and then save the remainder for the question period. A question to you again, Paul, from Kim. How are you able to manage multiple portfolio solutions while preventing future silos and patchworks in healthcare?
Yeah, we need to be flexible with the trajectory, because when it involves many different trajectory, and I should have said that before, it's a trajectory or a group of trajectory. And this concept was taken, I don't remember from where, but we were quite made aware early of this factor of making sure we could address multiple trajectory issues. The other thing we're observing in the practice is that sometimes we have things which are not specifically L trajectory but are transversal solution that could be applied to the healthcare system practically as a whole. Many of the information technology solutions sometimes fall in that category, and we're accommodating the process to describe those, although we're still asking the description of the benefits to be very specific.
Great. I'm gonna go back on my word. I'm gonna put in one more question, and maybe we can answer two questions at once. Melanie and Nadia have related questions. One is, what is the incentive for innovators to share their projects with the organization or with the ministry? And from Melanie is, can you give an example of the best application of the innovation so far?
The major advantage, the major advantages, because I think there's more than one. The first one is you get feedback right from the top decision makers in the healthcare system. I remember when I was in the industry, one of the issues was often not receiving feedback and not knowing where you were standing in a process. With this process we've built, you know exactly where you stand. Sometimes the answer is not sometimes it's not the answer you want, but you know where you stand. And that's of high value for the people who are presenting innovation. The second one is through the process, because none of the business plans that were presented yet were just taken as is to the Prioritization Committee. They were all coached. They were accompanied, and we do a lot of work with the people presenting innovation. And the final advantage is that instead of presenting the innovation in one forum, you've got all of the people in the same forum listening to the presentation at the same time. And that is leading to different type of discussion, because when the IT guy is listening to the priority from the specialist who require this innovation, his issues are still there, but all of a sudden they are put in a different context. So this community of listeners is providing the innovation a much better place to land, and is favorable to innovation. One example, there are many. So far we received roughly 30 projects in the bureau through the process of the business plan. We also receive others from another competition we've created that I'm not going to talk about because it would take too much time. But of the 30, I'll take one example. This is a project which is changing the way and the utilization of some of the stents in cardiology. The work was presented, and it was presented in a very meaningful and spectacular way. The basic work had been done with the institution in the province. The economic analysis were very profound, and we went directly from the presentation of this to implementation in the rest of the province. This is obviously our best example, but this has happened, and we were very pleased with that.
Super. So thanks so much for that. We're going to keep the remaining questions for you, Paul, for the questions at the end. And I'm going to move next to our presentation from Eric Sandy, President of MetaV Health Services, who, as I mentioned, is going to be talking a little bit more about the case profile that we have on our website. So I'll turn it over to you now, Eric.
Thanks very much, Bill, and thanks to you and Jennifer and CFHI for the opportunity to talk about this. So I'm going to talk about a real case example we have here, where we've created what we're calling an integrated primary healthcare model in New Brunswick. And how I want to approach that is really I got to give you a little bit of context, background on the organization in case some of you don't know MetaV. Then I want to talk about what the issues were in New Brunswick, where we saw a problem, where we believed we could provide some meaningful solutions. Then I'll go over the model, and then finally I'll talk about how are we actually delivering that value to the province of New Brunswick. What's the contract look like? What kind of promises did we make in terms of delivering outcomes and value to the province? So just MetaV, a bit of a primer here. So MetaV is an organization that has three subsidiaries to it. The first one is MetaV Blue Cross, which is a traditional health and dental benefits organization that essentially operates from Ontario East. The bulk of the business would be in the Maritimes. They manage about $4 billion in claims and Also manage a number of large government systems such as the Medicare system in Nova Scotia, the claim systems for Veterans Affairs Canada, the refugee program for the federal government, etc. We are, the second organization is MetaV Health Services, which I'll talk about in a second. And then an important point is our third organization, which is the MetaV Health Foundation. We are a non-profit organization, so we do pay a social dividend every year to the Health Foundation, which in turn is involved in child and youth mental health, type 2 diabetes, and post-traumatic stress. So MetaV Health itself had its genesis in creating a provincial EMS system in Nova Scotia in 1990. We're now involved in provincial health systems. We manage the EMS system for Nova Scotia, New Brunswick, and PEI, and then we've also got contracts in Ontario, Saskatchewan, and Alberta. We have a clinical training school which trains paramedics for employment anywhere, but we also do that for the Department of National Defense. And most recently, we've expanded into primary care health solutions in New Brunswick specifically, as well as 811 telehealth solutions. So we employ about 4,500 clinicians in 6 provinces, and one of the ways the organization has distinguished itself is if I go back to the EMS system and the employment of paramedics, we were really lucky, and that's a thread through all of this discussion, to have pretty visionary clients in various departments of health that we work for. In the case of Nova Scotia, they realized that there was an opportunity to use paramedics outside of the emergency setting, while operational expertise and clinical expertise in the emergency setting is the core business of an EMS system. They also realized there was significant clinical skill that could be used outside of the emergency setting. So I'll just touch on a couple of examples here. One would be the extended care paramedic program run in Nova Scotia and Saskatchewan, where we place paramedics in long-term care homes in a non-emergency situation, so they don't have an ambulance. And they're able to manage low acuity health issues for the people in those homes right at bedside. And that's reduced trips to the ED by 74%. And the remainder of the trips are essentially facilitated trips where we can, for example, schedule an X-ray for someone who's broken their wrist and get them in and out of the hospital quickly. So the main learnings from that are really, yes, we can assist with keeping the acute system, their EDs less busy, but it's really about quality of life for those people in the long-term care home and being able to assist them right where they live. Another one, if you go to the far right of this slide, is a palliative care program that we launched in Nova Scotia and Prince Edward Island, where we increased the scope for every paramedic in those 2 provinces and gave them additional training to assist with palliative care patients. So after hours and on weekends, instead of transporting them to an acute setting, we're able to manage many of their issues, whether it's pain management or a respiratory issue, for example, right at bedside. And these are early numbers where we've reduced transports by 35%, but it's inching its way up towards 50%. And we're quite proud, actually, that that's one of the models that CFHI is using in a collaborative across the country to talk to other provinces about how they can also assist people in a palliative setting. The main point here is that the organization has really been focused on delivering primary care in an innovative way in the community, and that we've got about a 20-year track record of doing that. Now, if you move to New Brunswick, they have a very innovative organization there too called the Extramural Program. Now, the Extramural Program is often described as the hospital without walls or healthcare without walls. And if you think of any clinical nursing organization in your particular jurisdiction, they would do many of these things. The EMP program has a collection of 9 or 10 different types of clinical providers, lots of nurses, but also OTs, PTs, speech pathologists, etc. So their mission is to provide inclusive services to people in their homes or communities, to provide a solid alternative to long-term care facilities, to reduce trips to the acute system, certainly readmissions, to facilitate effective discharges back into the home and the community, and then to keep people as independent as they can, where they can be healthy and happy in their home. So as I mentioned, we have a number of different clinicians, clinical providers in that situation, and they're all working very, very closely in a variety of different areas around, acute care, palliative, supportive maintenance, and rehab. I think it's about 1,000 nurses in this organization, or 1,000 clinicians. This organization has exclusive responsibility for clinical care in the home and working with the physicians along with their patients. Now, if you look at New Brunswick itself, it has a whole host of problems which will look familiar to all of you wherever you happen to work in the country. But New Brunswick has a very rapidly aging population. And so a lot of the trends that you'd see elsewhere are really quite advanced in New Brunswick. So there's a very high rate of chronic illness. It's got the highest rate of ALC beds in the country. It really needs to find new ways to be efficient and effective and to build capacity for the system. We knew that there were variations in care across the province, and mostly rural settings versus urban settings, that type of differentiation. And our thought here was that if we could create an integrated system to manage care in that province, we'd be able to help the province meet a lot of their goals in terms of caring for people in the home and the community. So what we proposed to the province was that if you took 3 of those organizations, so Ambulance New Brunswick with its paramedics, the Extramural Program with all of its clinical providers, and the 811 telehealth service with its clinicians, again mostly nurses, and if you integrated them into one organization, we could be far more effective at delivering community care than they could be as individual organizations that are quite siloed. Now each one, I got to say, did an outstanding job on their own. There was really, nobody was complaining about quality of service or quality of focus. They all did an outstanding job. But we believed if you could integrate them, there are going to be a lot of benefits that could happen through enhanced communication and coordination and continuity of care. So we would be able to assist the province in keeping people home as long as possible, help patients navigate the healthcare system, again, think about the continuity of care, make sure that that was in place. And essentially, with a roster now of a whole variety of clinicians, we could make sure that people got the right care in the right place at the right time. And I guess in brackets for the province at the right cost. Although that was not the driver, that is one of the benefits, and I'll talk about that in a second here. So again, there are a variety of benefits with this model. For patients, it's about navigation and access, reduced ED visits, and a proactive approach to their health. For the providers, there's a chance for individual providers to practice closer to the scope, top of their scope in their particular discipline. And they were, good clinicians are always looking for better collaborations with colleagues. And then for taxpayers, there was a story around the realization of synergies around administration and bending the cost curve. But it was really for this particular province about building capacity to deal with the demographic curve that was headed their way in terms of an aging population. If I turn to the contract models, we've had a variety of contract models. I don't know that we'd ever have described them as value-based healthcare contract, but we did always start the discussion with talking about patient outcomes and the cost of that patient journey. So without knowing it in terms of phrasing it as a value-based healthcare program, I think we were essentially looking at that program quite specifically. So all the contracts share a number of elements. There's certainly going to be performance standards. There's a budget attached to it. There's a management fee and risk-sharing incentive, some way for us to get paid for the work that we're doing. Because these are often long-term contracts, 10 years and further out, there are adjustment periods if there are variations in environmental conditions. We always try to protect funds to be reinvested back into the system so they don't just, savings don't go into the black hole of general revenue. And then we want an incentive to share with the province so we can be effective stewards of the public purse in all of those contracts. If we focus specifically on what we're doing with the EMP contract, it's a 10-year contract, so it started in January. There were 3 phases to the contract, and we're just ending the first phase. The first one was to integrate the Extramural Program, Ambulance New Brunswick, and 811. So how do we bring them together and find those synergies that are required to really make the model effective and to bring that continuity of care and enhanced coordination. Secondly, we'd be looking at building what we call a Health Services Coordination Center or a command center. So we have plans to take the communication center, which is the logistical heart of any ambulance system, and add components to that so that we can look at the entire spectrum of care in the community and coordinate it effectively so we can make sure we have the right clinician in the right place solving the right problem, and that a team-based approach is available for that patient and their family, and also to help them navigate when they have problems. And then the third phase is once we have that done, and we've helped move along the continuum with people that are identified as being in the community. We start to look outside the identified patients and find those with complex needs who aren't currently under any sort of a case management program, don't necessarily have a physician, but we know are cycling in and out of the acute system when their chronic conditions or their comorbidities exacerbate to the point where it becomes a very serious situation for them. So we think this model that we have is pretty unique in Canada. We haven't seen any that are too similar to it. One of the things that we have done is we have gone at risk with the province. Now, what's important to talk about here is when we first talked about this with the province, first off, we again realized we had a visionary client in the province of New Brunswick. The Department of Health there in particular knew that they had some big problems and that incrementalism wasn't going to solve it. They were prepared to try a new model with of course, the risks thoroughly thought through and boundaries on that, but they knew that they needed a new approach. Critically, the first discussions we had were with both the Minister of Health and the Minister of Finance. We knew we had to make an appeal to the Minister of Finance so that there was a strong support in the Cabinet along with the Minister of Health to approve a new model, which did bear some risks. And then finally, we knew that we had to take some of that risk burden on ourselves to do that. So we structured the contract after lots of discussions with the province so that we had to measure 5 very specific metrics in order to get compensated. Now, behind the scenes, there are dozens of metrics that are measuring performance that are very important to the Department of Health, to our colleagues in the acute system, and of course to ourselves to make sure that we're effective and efficient and managing the program properly. But in terms of compensation, we've got 5 things that we're attempting to do. The first is we want to reduce ED visits. So we have a sliding scale, but our promise is to reduce the number of ED visits from identified community care patients by 15%. The second is to increase capacity. So how do we increase the number of visits to the home? So again, we believe we can increase capacity by 15% without adding any FTE, and that will be through smarter integration of the team members in the community. The third piece is patient experience, and interestingly, we do not get rewarded for that, but we do get penalized for that. We have to maintain a patient satisfaction rate of 95% or higher as a baseline, and if we drop below that 95%, we will have to pay a penalty for that. We need to increase referrals and work with the physician community to make sure that they are referring into the system. So there are a variety of measures there. So we know that the physicians are referring in. And then referral to care time. We know that we need to increase the time from the order of care to the delivery of care. So for example, if it was an average of 3 days from order to getting a nurse to come in and do an assessment, we're going to get that down to 1 day over a short period of time. So those are the 5 key metrics upon which the value is demonstrated. We also do have a cost savings incentive where we will share cost savings up to a limit with the province so that we do keep our eye on our budget and make sure that we are being good stewards of the provincial budget as well. So we are in year one, just finished the first year, and I'm very happy to say that we are making very strong progress against the metrics. The province is quite pleased with the progress. We're pleased as a nonprofit organization that we're able to share in some of that progress. And more importantly, we think we've built a new model here that really has the potential to improve the lives of tens of thousands of people in New Brunswick that want to live long, healthy, and happy lives in their home, and that we are a tremendous partner for the province in making sure that that happens at its highest level. So with that, I will wait for any questions or comments. So thank you very much.
Thanks so much, Eric. So recognizing that we're at time, we're at the full hour of the webinar, I know some people will have to sign off. We are going to stay online for another 5 to 10 minutes to answer a few more questions before we officially sign off, and we'll commit to responding by email with any responses to questions that we aren't able to get to. And a few reminders that we are recording the webinar. We'll send out the recording and the slides within a few days. And we have a feedback survey, and if you could take a few minutes to complete that, we'd really appreciate hearing, if there was anything that you hope to hear more about or what you might like to see on a future event. So we'll launch right in with a few more questions. To Eric, a question from Dr. Chowdhury, and I'm going to reframe your question a little bit. The question is, given the ever-evolving landscape of patient safety, Eric, do you have any thoughts on metrics for patient outcomes and patient safety?
Well, if we talk about patient satisfaction first, we're not doing that ourselves. We're working with the Health Council in New Brunswick, which is an independent body that does an independent measurement of these factors. And so they are going to be the people that adjudicate whether we've got good progress in that regard. In terms of the role of the patient themselves, we do have family and patient and family advisory teams that are embedded in most of our key processes. So, part of that discussion would be their experience and their journey, but also issues around safety. Now, I mentioned we also have a whole raft of other metrics behind the scenes. The 5 I talked about here are the ones we get compensated on, but behind the scenes we have many, many measures around patient safety and clinical quality, most of which would be familiar to the clinicians on the line, and we can certainly offline get you copies of that or talk about that.
Perfect. And a bit of a follow-on question from Lena at the BC Ministry. She says, fabulous that patient perspective is measured. She's curious how you're measuring patient perspective. Is it using a validated tool? Will it be reported publicly, etc.?
Yeah, so I just talked a bit about the Health Council in New Brunswick. It is a public process, so they do rack them and stack them, as they say, so that information is available to the public. And the metrics that we are measuring are also on an annual basis available for the public so they can see our progress. We do report into public accounts at the government once a year. We do that for Ambulance New Brunswick as well. So all of that data is available.
Super. And we know, in addition to the patient perspective, it's also important to think about the provider perspective and experience. And Kim's asking, how do you get feedback and evaluation from the provider perspective in order to improve the system?
Well, we do, employee engagement surveys, and we do talk to staff across the organization to get an internal perspective on that. We also, anecdotally, one of the interesting things, at least we have heard, is that the staff generally is quite pleased to be in an organization that's focused exclusively on community care. So, the concerns of the providers and our employee, how they think about their patients, that's what we wake up worrying about every morning. So that is our exclusive focus. So I know that a lot of people are quite pleased with that. But beyond the anecdotal, we do, as I said, do employee communication or engagement surveys and get feedback on that.
Thanks for that. So Kim, let us know if that responds to your question. Another question to you, Eric, from Lise, asking about, you talked about the complex needs and aging population, and in your performance measures related to the patient experience, is there a language of service measure?
I guess I need to know more what is meant by a language of service measure. You know, in terms of the complex patients, one of the interesting parts about our relationship with the government is like I said, it's a 10-year contract, and we've agreed that, you know, as we move through those 10 years, we will have an opportunity to work within the contract to change the measures, to add some, delete some, and make sure that we're able to shift our efforts to meet the needs of the province as interpreted by the ministry. So as we get more deeply involved with complex patients, I expect to see a new series of metrics that are before us that outline the priorities of the government.
Okay, and so thanks, Eric. I'm going to try to get to a few more questions that we didn't get to earlier in the webinar. There are a few questions from that were really directed to Jennifer, I believe, from Quentin, PJ, and Steve. So we'll follow up after the webinar with responses to those. And a question to you, Paul, from Joanne. She's wondering if you can provide an example of how value-based procurement is included into projects.
Two things I will say about that. The first one is we've been working with the procurement people at the Ministry of Health and Treasury to integrate the value-based procurement process within the business plan process. So if you want to propose something which requires value-based procurement, you can go through the business plan process, and if it applies, you'll automatically be taken to that other process, which is value-based procurement. The other thing we're doing is we've identified five opportunities, with companies that are prime projects for value-based procurement, and we're working with those examples as the lead example that we would push rapidly through the system, so that we would create early examples and early practices on value-based procurement, because we're not far ahead with this, and we really need to be moving. So those examples are in the process right now, and we hope that within the next 3-6 months we would have examples of actual value-based procurement that have taken place.
Thanks so much, Paul. And so I think we're going to close off the webinar in the final 2 minutes. So I see Kim and maybe Lise are commenting. Okay, one more question from Kim is to you, Eric, if there's any valuable lessons learned with presenting this new model, in addition to involving the Minister of Finance, which is an excellent idea.
Well, yeah, I mean, we could talk all day about that, but, you know, I think one of the things to think about is, you know, the status quo can be a pretty formidable opponent, so you've really got to think about having a very compelling reason to change the status quo. So, I mean, that may seem quite obvious in Sales 101, that type of thing, or Business Model 101, but you really have to have thought through that value proposition. And the greater the change, of course, you know, the greater the benefit you're going to have to be able to document. And I think the fact that we went at risk on it also showed a very strong belief on our part that we, quote, had skin in the game, that, you know, we believed in it so much that we were willing to risk our position financially to more or less guarantee the outcomes would happen. So that's really important. I think if I talked about our organization specifically, there were also a lot of misperceptions around publicly funded but privately delivered healthcare. I think everybody on the call is pretty acutely aware of that. But even as a non-profit organization, working to improve healthcare as our, basically our mission, there's still a lot of people that aren't that comfortable with the idea. So I know this is getting a lot of airplay in Ontario, but where community care in most provinces has historically been delivered by private organizations, a lot of nonprofits. In this case, there was quite a bit of debate about the role of a third party in this healthcare delivery. So organizations like ours need to think that through as well. And then I think it's really, really important that you find someone who, in the local government, the Department of Health, that is a champion. You need to find a visionary, someone who is willing to take that risk along with you and is really passionate and focused about patients. And we were just very, very fortunate to have that kind of leadership in this particular province.
Thanks, Eric. So we will wrap up now with the webinar. Thanks, everyone. We'll be in touch to follow up to answer some of the questions we weren't able to get to. Before we end, I just want to say a special thanks to Jennifer, Paul, and Eric for their presentations. Thanks to everyone online for joining us, for your great feedback, comments, questions, and insights, and sharing some of the work that you're doing across the country. And also a special thanks to some of the people working here at CFHI behind the scenes to make sure the webinar is successful. So shout out to our producers, Sheena Powell and Katrina DeMont, who are here with me, as well as Jessica Fournier, who's been supporting our chat box and the question period. So with that, we'll close up, and I want to thank everyone again and hope everyone has a great day.